Hey, Dr. Liegner. This is Harrison from the Disulfiram for Lyme Facebook support group. I just wanted to say we've been really excited about your recent published article. It's created a great deal of excitement in the Lyme community. First, I wanted to personally commend you for being the first Lyme doctor who was willing to go out on a limb and deviate from the current standard of care for Lyme to help his patients with a potential new breakthrough drug, which in this case is disulfiram. And I also wanted to thank you for having the courage to publish the results to mainstream medical doctors with your first three patients, because I'm sure you knew you were potentially opening yourself up to a lot of scrutiny from the wider medical establishment. So yeah, thanks for publishing the pioneering article and for doing all that work for the benefit of other patients and Lyme doctors. And thanks for allowing us to interview as well.
Thank you, Harrison. I didn't actually feel like I was going out on some kind of a dangerous limb, actually. But
Really, that's good to know.
yeah, but again, I never would have suggested it to my patients. It was only because my patient suggested it to me. I did it. I used it.
They suggested the drug to you.
Yeah, I mean,
Oh,
I wasn't
interesting.
even aware of the work. Um, well, maybe I was aware of it, but it was really, the Kim Lewis video that was recorded during the first Mount Sinai um, symposium on Lyme disease in the era of precision medicine. That was October of 16, which I wasn't even aware of that symposium at the time. And this particular patient was a very bright guy. He was following the work of Kim Lewis for quite a while. Probably he became aware of Kim Lewis's work maybe just a little bit after I had become aware of his work. And so he was following Kim Lewis, and somehow he must have become aware that there was this, video on YouTube um, that that recorded, well, the entire conference was on YouTube, but particularly Kim Lewis's keynote speech. And towards the end of that speech, he referenced the work of Drs. Pothaneni and Raja Das out of Stanford on that high throughput screening, which identified disulfiram as basically the most active agent, bar none, that's an agent that's FDA approved.
Yeah, that work by Dr. Rajadas at Stanford has definitely been underappreciated, and we're looking forward to potentially interviewing him as well in the future.
That'd be great.
Yeah. So basically, that actually led me into my first question. How did you first heard about DSF through one of your patients? I take it then, right?
Well, I mean, I was aware of disulfiram as an agent, as antabuse. You know, anyone who trains in medicine would know about its use for the treatment of alcoholism. But I had never used it. I'd never prescribed it. I just didn't know too much about it. Um, and then when this patient asked of me whether I would allow him to try it, then I, started doing more research into it and learning more about it. And then, as you know, he was the very first patient. I guess my guess is he is the first human known to be treated with disulfiram treatment of tick-borne illness and Lyme disease in particular. And the results were so unbelievable that with his case that I mentioned it um, selectively to a couple of other patients whose care also was difficult and problematic. And then the second and then the third, we had these unbelievable results that, my staff and I and my nurse Dawn and I, we're kind of pinching ourselves, like waiting for the other, shoe to drop because it was just so incredible. These were patients who were very well documented and whose care, I mean, they did respond to antimicrobials, but whenever you stop, they would relapse. So you got into this very problematic situation of a need for open-ended treatment, which of course that's what we have had, and as you know, that is very controversial within the medical community. Um, but it has been necessary, unless you want to, like I've said before, unless you want to, like I said to that reviewer too in my article, unless you want to abandon patients to their fate and just let them deteriorate. So have an agent that is actually not an antibiotic in the usual sense is relatively safe. Not that it doesn't have some risks. And I like to say that's as cheap as borscht, relatively speaking, and very, very potent. It's amazing.
So when was the first patient that you put on disulfiram?
Well, my patient viewed that video sometime in maybe in the late fall or early winter of 16. He brought it to my attention. So I viewed the video, and then I went to the work by Potaneni out of Stanford and read the article. And my patient was, he was very respectful. I jokingly say he twisted my arm. He didn't really twist my arm. He just made a simple request. And I thought about it. And after I informed myself about the drug, and I thought to myself, well, here's an FDA-approved agent. It's been around for 60, 70 years. It's fairly safe. And we have all these patients because, as a physician who cares for patients with a disease that doesn't exist, chronic Lyme disease, we kind of collect these difficult cases that nobody else wants to take care of. And so I have many patients like that first patient, and some of them even more difficult to manage. The first patient was able to at least be managed with fairly simple oral antimicrobials, but there are other patients, despite one's best efforts using oral agents are not adequate. So that becomes even more problematic. Then you're talking about either intravenous antibiotic therapy or intramuscular antibiotic therapy, and those are not the best solutions, but that's what we have had. So when this patient he'd been trying to come off, we were able to get him to a point with intensive oral therapy where his condition was fairly good, but nobody really wants to be on open-ended medication, right? Antimicrobials, not the greatest thing. So he actually made a number of attempts to try to come off, and he'd do okay for a little while, and he would invariably deteriorate and be forced to resume them. So I'd worked with him for 7 years. He's an engineer. He's a rational guy, and when he asked me, I agreed to let him try it.
So that was approximately 2016?
He was started on disulfiram St. Patrick's Day, 2017.
Oh, 17. Okay. So I think you're the first doctor to prescribe this off-label for Lyme disease. Do you believe that's the case?
I believe that's the case, and only because of circumstances. And again, I never would have suggested it to my patients. It was only because he requested it of me, and I didn't think it was unreasonable. And I said, okay, here's the deal. Stop your other drugs, because otherwise, how would you ever tease apart what disulfiram does or doesn't do? So he stopped he was on high-dose amoxicillin. We're talking about industrial strength dosing of amoxicillin, high-dose minocycline, and high-dose malarone. And on that regimen, he did pretty well as long as he was on it. So he stopped that, like a little bit in advance, and then he began disulfiram. And again, at that time, I had no idea what the dosing ought to be. So I just looked into the literature about what the usual range of dosing would be for someone where it was being prescribed for alcoholism. And so I just kind of chose a number, 500 milligrams a day, and I gave him a prescription for it, and I gave him order for a standing order for surveillance labs. And I said to him, have your labs done on a fairly frequent basis, and send me a note every couple of weeks, let me know how you're doing. And he did all of that. And the labs were fine, and he did send me notes every once in a while. He lived at some distance. It was not so easy for him to get to the office, and he was doing fine. And then a couple of months later, he left a message on my office voicemail, canceling his follow-up appointment, and declaring, quote, "I'm cured," close quote. And he mentioned in passing that he had required a hospitalization, but he didn't tell me why. So naturally, I was very curious, and I called him back and spoke with him, and he mentioned to me that he had required psychiatric hospitalization at that time. So at that point, but he said, I'm fine, I'm doing well, and was not on any psychiatric meds. And then I did some more research, and that's when I realized that occasionally disulfiram can cause neuropsychiatric problems itself because it affects neurotransmitters. I called him back, and I told him that, and he said to me, I don't really think it was from the disulfiram. He had been under a lot of situational stress at the time. But then he said, but even if it was worth it. And don't fail to offer it to other people just because of that. So he admonished me, and we've been keeping in touch with him, and he hasn't needed to come back in. My office nurse just spoke to him within the past week or so, and he's remaining well, greater than 2 years out, something like 27 months since stopping the disulfiram.
Do you know if he had Bartonella and Babesia?
He had babesiosis, to the best of my knowledge, not Bartonellosis, as far as I could tell. And that's the other incredible thing, that these patients who have Lyme and babesiosis, their need for babesiosis seemed to also be eliminated with the course of disulfiram, and that's like unbelievable. So like to be able to impact two big, difficult infections to treat with a single agent that's inexpensive and for a finite period of time, also like astounding. And I didn't go into it thinking that this had any activity against babesia, but it turns out it seems to. And babesiosis is also very, very problematic. And even the mainstream is acknowledging that our wonderful treatments for babesiosis are not very good. So, contrast, a couple of months of disulfiram versus open-ended treatment with azithromycin and either Tovacon, so-called Mepron, or Malarone. Those are very expensive drugs, and the conventional wisdom is that 10 days of Zithro and Mepron and you're cured, and that's obviously false. And even Peter Krause, who reported on the use of zithromycin and Mepron early on and recommended 10 days, he recognized that there was persistent parasitemia after that treatment, and it sort of was like ignored. Well, what does that mean? Supposed to just ignore the persistent parasitemia? Not just persistent parasitemia, people are symptomatic. And so clearly we need better methods of both diagnosis and treatment for many of these tick-borne illnesses.
Yeah, tell me about it. So I did want to ask, do you think the reason that first patient was able to tolerate the 500 milligrams right out of the gate, is that likely because he had been treating very heavily with other antibiotics for a long time and his bacterial load was probably fairly low to begin with?
That's a really good point. Yeah, I mean, he was relatively well compensated. So certainly he had a burden of infection, but it's a different situation than taking somebody who's not well controlled or hasn't been treated, and who has a high burden of infection. Yeah, he tolerated the treatment pretty well, except for psychiatric hospitalization if it was related to the disulfiram, which neither he nor I are certain whether it was related or it was contributory. But Yeah, he seemed to tolerate it pretty well. Other than that.
So, do you mind telling us a little bit about the other two patients in your published article or clinical trial, how they're doing as well? Some of the people in the group are quite curious to hear.
Sure. So after having that experience with case number one, and again, us clinicians who care for the patients, we're confronted with this all the time. It's very problematic. But we haven't had any options. And the mainstream certainly hasn't been so cocksure that the treatments are perfect, and haven't even been looking. And it's only because of the privately funded research that any progress has been made at all. And there's the four groups. There's the Ying the Zhang group at Hopkins. There's the Kim Lewis group at Northeastern. There's Eva Shapi at University of Haven, and Dr. Rajadas's group at Stanford. Those are the only groups that are actually acknowledging the problem of persistent infection with Lyme and trying to see if we can come up with better methods of treatment. And the amazing thing is with relatively, limited period of time, they've come up with some, really important hits, not just disulfiram, but, other agents that have activity. So anyway, yeah, what was the question? Sorry, guys. Okay.
Yeah,
Yeah,
no
so
problem.
the second patient um, was his care was very, very problematic also. He was a retired physician. He lived in Pennsylvania on, I think, 20 acres and had like 4 indoor-outdoor dogs. And had been sick, before he came to me, and he'd already received a couple of rounds of antibiotics, including intravenous antibiotics, before he came to me, and he was really, really sick, and had bulletproof central nervous system Lyme. And you could not ask for a better documented case. And in addition to many physical symptoms, quite severe, he had very significant neuropsychiatric symptoms that he had been under the care of an excellent academic psychiatrist. And it turned out that he required very, very intensive treatment, both medically and psychiatrically, to barely keep his head above water. And when he was under my care, we did try different regimens, orals, and again, he is a case where oral therapy was not adequate, and he required a long course of intravenous antibiotic therapy. I was not the treating physician; his local physicians were treating him, but of course, I supported that treatment. And he, with maximally intensive treatment, he did fairly well, where he could enjoy a fairly good quality of life, not perfect, but he was able to get by. He had one episode of quite serious, even life-threatening sepsis related to his intravenous catheter, and after that, the local physicians understandably were not interested in treating with intravenous antibiotics. So at that point, because the orals were not adequate, he was treated with intramuscular ceftriaxone, which is quite a practical method. And he was on that for, I don't know, 2 to 3 years, which, as you might imagine, I mean, again, he didn't have a choice. We didn't have a choice unless you wanted him to, deteriorate into, misery. And but you can imagine getting intramuscular injections, or he administered them himself. Again, being a physician. So and he required very intensive psychiatric treatment too. Besides oral psychopharmacotherapy, his psychiatrist, because his depression was so dense and so severe, he had required intravenous ketamine infusions every month or so in order to keep his depression under control, which is, again, a pretty extreme thing to have to do. So when I reported to him the unbelievable results we had with case one, he thought about it. Again, he's a physician. He discussed it with his his other physicians, he had a very fine local primary care physician, an excellent psychiatrist, and an excellent neurologist locally. And he discussed it with them. I discussed it with them, and realizing, okay, this is based on one single patient. Not a lot of data, but everybody agreed that it was worth taking a chance. So he was the second patient, and again, he's also. And by the way, the first three patients were all 200 pounds plus. Third patient was 220. The first two patients were about 200 pounds, and so we did the same thing with the second patient, and we discussed with care, with his other doctors, the other medications that he was on, and this patient, unlike the first patient, really it had a very profound impact on him, and basically he was fairly bedbound during the first 6 weeks of his treatment, and fairly debilitated by the treatment. And then at the end of the sixth week, he was going around somewhere, and he had a fainting spell, syncopal episode, hit his head, had a concussion, needed to be hospitalized. Luckily, that he did not sustain any serious injury. But because of that, his neurologist recommended to him that the disulfiram be discontinued, which was completely reasonable at the time. So when I heard that he had the concussion, I called him, a week or so later, and then he says to me, "I think the treatment worked," and he's been followed. He was doing quite well for greater than a year, and not just well, but incredibly well, much better than he ever had been with his most intensive antibiotic therapy, and also amazingly, he was able to wean off with his psychiatrist, wean off most of the intensive psychopharmacotherapy that he had been on. He was able to discontinue the ketamine infusions, and he had an excellent quality of life. He was really back to what he felt should be a baseline for a fairly normal, healthy kids at that time. He was in his late 70s, I think, at that time. And so it was like, again, incredibly impressive. He recently recontacted us because he had sustained another tick attachment, and he had asked to be treated for the tick attachment, and the mid-level at his physician's office declined his request. And so about 10 days later, he developed a small rash, and he started getting sick. And finally, he got 21 days of doxycycline. And meanwhile, his psychiatrist was very comfortable with the disulfiram. Even before he came back to see me, put him back on disulfiram, 500 milligrams a day. And when he saw me, he was already on that. And we just reassessed him, and the plan is for him to repeat what had worked before, which is to be on disulfiram for 500 milligrams a day for 6 weeks and then stop and observe. And so again, he was doing extremely well, and so we think that he probably got reinfected, and that's why he developed symptoms. But he was doing really well for more than a year, and this is a guy who had required incredibly intensive treatment, again, to keep his head above water. So very dramatic.
Wow. That's amazing to hear that you've had such great results. So, if you don't mind, the group has left me with a bunch of questions that I'd like to follow up with pretty quickly, just so that I don't take up too much of your time. How many
Before you
patients?
do that, because I know patients are curious about the state of those first three patients.
Oh, we
So
only
let
got
me
to
just tell
two,
you
right?
about the
Okay,
other one.
go
The
ahead.
other one, he weighed 220 pounds. He tried, and he was pretty, functioning, well functioning, even though he had required fairly intensive treatment, before the disulfiram. And he tried the 500 milligrams a day, and it just knocked him for a loop, and he just couldn't handle it. He wasn't able to go about his normal activity. So he was the first patient on his own advice who greatly reduced the dose to a half of a 250 every other day. And he found that he could tolerate that. And then he slowly ramped up the dose over about 2 months to get to the full dose of 500. And then he was on that for 2 months and then stopped and enjoyed what seemed to be a really great remission for about 6 months. At the 6 month mark, he was local, so he came in and wanted to be tested, which I really didn't want to do because he was doing well, but he sort of insisted, and fine, and the cost of his testing was covered by his insurance. So we went ahead and did it, and then he ended up having a positive Lyme PCR at a time that he told me that he was feeling well. So I was really upset by that because I didn't know what to make of it, and I was almost disbelieving of it. But then over the next month or two, he developed his fairly typical symptoms and of Lyme, and so he just was retreated with a longer course of disulfiram. I had intended him to be on 750 milligrams a day, figuring that maybe that would be better for his weight of 220 pounds. But he found he couldn't handle 750 a day, so what he did was 750 2 days on and then nothing the third day. Well, that actually ends up being the exact same dose that he was on if you total it up for the month as 500 milligrams a day. But he was on it longer. He was on it for 3 months. He came off it in July, and we've just been in touch with him. He's going to be seeing me later this fall, but according to my nurse, he's doing extremely well. Having done that second course, but what the ultimate outcome, we're not sure. And also, he might have relapsed. That's a possibility, but also we can't completely exclude the possibility that he was reinfected because he's an active out-of-doors guy. But he didn't think he had another tick attachment after that first round of disulfiram. So that's where we are with those first 3 patients.
So in summary, just to put it in like a few words in case people weren't able to follow the whole thing, it sounds like all 3 are doing fairly well.
Yes, and
either in
the
remission.
first one has enjoyed this very enduring. I don't want to even say cure because I don't know whether people are cured, and you don't even have the means to know with our not very good tests to know that. But case 1, 27 months out, is doing extremely well. Case 2 was doing extremely well for greater than a year, and then had a tick attachment, and we think he got reinfected. Case 3 may have relapsed regardless of whether he was reinfected, and then has been retreated, tolerated the treatment, and so far from July until September at least states that he's doing extremely well. And the other thing is all 3 of these people also had babesiosis, and where babesiosis was also very problematic.
What about Bartonella? Did they have Bartonella?
To the best of my knowledge, none of these 3 had Bartonella, as far as I know.
So the third one, what was I going to ask? Is he? Oh, you said that you thought he might have had a tick reattachment, but you're not sure. Oh, my question was, how long did he stay on the 500 milligrams dose per day during that first round of treatment?
He was on 2 months, 8 weeks, and once he worked up to the full dose, he was on 500 milligrams a day. He was on altogether 4 months. The first 2 months were kind of a ramp up, and the second 2 months was at 500 milligrams a day every day.
So at least in his case, you said the PCR was positive?
PCR that was obtained in November. So he finished treatment. It was Memorial Day of 18, I think. And then he was seen in follow-up November of 18. And that's when he asked to have a fairly thorough reassessment. And that's when we detected a positive Lyme PCR. And I was trying to rationalize what that meant. Because I've been going by the notion that a positive PCR implies that there was active infection up until maybe a month or so before it was detected, because when you detect the DNA, you don't know if it's living Borrelia or dead debris, but the work of Reinhold Straubinger at Cornell indicated that if you administer heat-killed Borrelia, he did that to beagle dogs that were not infected, that it took about um, 3 to 4 weeks for the DNA to be completely cleared by the system. And then I'm saying, well, that's what I've been going by, but maybe the situation is different. And somebody who's harbored Lyme for, decades, that maybe there's a longer washout period from, niche reservoirs like the eye or the brain. That's how I was trying to, because at the time it was detected, he told me that he was clinically well. I'm thinking, well, maybe my assumptions about how long it takes for Borrelia DNA to clear the body are mistaken, But in retrospect, it turned out that really didn't indicate in his case that he was dealing with an active infection, either whether it was a reinfection or a residual that wasn't eliminated by the first course of disulfiram.
It did indicate that he was dealing with an active
Yes,
infection?
because he clearly became symptomatic in the subsequent month or two, and that caused us to go ahead and offer him another course of disulfiram. I had intended it to be at a higher dose for a longer period of time, but it turned out that he couldn't tolerate the higher dose, so he ended up, um, uh, at basically the same dose that he was on, but at that full dose for 3 months instead of 2.
So you have at least one case where the patient took a full 2-month course at the 500 milligram per day dose who did have a reactivation or relapse in symptoms from the Borrelia.
Yeah, I'm assuming that it was a relapse, although it's been pointed out I can't 100% rule out that he might have been, reinfected. He didn't think he was reinfected.
But you're pretty confident he was compliant with the 500 milligram per day for the full 2 months?
I'm pretty sure. He's a very independent-minded guy, so he might have, like I said, I intended him to be on 750 a day every day, and he found he couldn't tolerate it, so he did 750 2 days in a row, and then took a holiday on the third day. And if you add up the total doses, it's the same as if he did 500 milligrams every day. But in any case, even if that's so, he was on it for a full 3 months at that regimen. So we'll see if he has a more enduring remission. But as he said to me, Doc, if I had to do disulfiram and repeat it every, couple of months or twice a year or once a year, I mean, how much more beneficial is that or acceptable is that than having to go on either IV or IM ceftriaxone and gobs of, he was not able to be kept well with a standard dose of tovaclone or Mepron. He needed double and triple doses of tovaclone. So, like 3 teaspoons twice a day in order to keep his babesiosis under control. Otherwise, he would have drenching night sweats. And he was fortunate because of his circumstances that this was covered by his plan. That's $1,000 a bottle. So a bottle lasts a month. So at triple dose, that's like $3,000 a month for tovaclone. That's like ridiculous. Again,
And he's finding equally as good results with the disulfiram for babesiosis?
better,
Oh,
way
wow.
better.
That's really impressive.
It is.
Do you have any other noteworthy patient stories that you'd like to share?
Well, here we have this agent. It's a tool that we have that we didn't have before. And I'm the first to say that we're all learning. Here's this tool, and now we're trying to figure out what's the best way to use it, what's the wisest way to use it, how can you use it to extract the maximum benefit and try to minimize, adverse, reactions. So again, the dosage and duration that I used with these first 3 patients was quite arbitrary, but I'm learning from them, and I'm learning from my other patients, of course. And at this point, we have utilized it or are utilizing it in total of about 50 individuals, 30 of whom or so have completed it, and 20 are in the midst of it. And I will be giving a talk at ILADS in Boston in late October, early November. And also the same folks who at Mount Sinai School of Medicine who hosted that first symposium, when my article was published, I forwarded it to them and told them that if they would like me to speak, I'd be happy to speak. And again, happily, they actually have invited me to speak. So I'll be speaking on October the 19th on that. So in view of that, I've asked my office nurse, Dawn, to try to, together to review all the cases and try to categorize, what the outcomes have been, what kind of adverse effects we've seen, and who's been able to enjoy it, what's a seemingly enduring remission, who had a remission then relapsed, need to be retreated, who didn't benefit from it, what some of the adverse effects were, and so we're trying to roughly tabularize that. And again, I'm not a guy who does like clinical trials. It's not my background in training, and I don't even know how to do Excel, so which I should learn. But so we're kind of doing it the old-fashioned way, looking at reviewing the charts and trying to categorize them. And Dawn is in the process of doing that. And whatever we have is still going to be like an interim, summary. It's like there's 20 patients right now where it's still underway.
So out of the 30 that have completed, how many would you say are in remission?
I don't exactly have a number, but there's a sizable portion seem to be enjoying an enduring remission. I don't even know the numbers, but I mean it's enough for us to be very impressed, because we haven't seen that with other treatments. And again, I want to emphasize that I don't think it's a panacea. I don't think it's a silver bullet. I don't think everybody's going to enjoy that kind of an outcome. Most of the patients who have been on it report feeling that being on it was net beneficial to their status. There are some exceptions of people who did not find it beneficial. So
So out of
yes.
out of the patients who are not responding to treatment, do you have any idea why they might be failing this treatment?
Well, one patient, the patients who seem to respond well are the patients where there is a track record of them actually being antimicrobial responsive. In other words, first of all, I have a pretty good handle on what they have, because I've got good documentation clinically and from the laboratory of their diagnoses. And they've demonstrated that they respond to treatment but relapse. So one of the patients who didn't respond, I was pretty confident that he had Lyme. He had a good history and he had some reasonable laboratory support. But very nice young man, and we really tried everything in our bag of tricks for antimicrobial therapy, and he just never seemed to have a very convincing response. And we were hopeful that maybe disulfiram would be helpful where the others were not. And he, did the course, and he was quite compliant. And unfortunately, he was honest, like we encourage our patients to be, and he really didn't see any benefit. And at that point, I really encouraged him to, get additional consultations to try to figure out, what the mechanisms were that were, interfering with him being able to have a normal life, whether it was autonomic dysfunction, maybe he needed that to be addressed, and maybe he needed some other, kind of treatments. So actually, I've asked Dawn to get in touch with that individual to get some late follow-up on him. There's another patient who had positive Lyme PCR in his spinal fluid and had quite a bad neuropathy from Lyme, even before anything to do with disulfiram. And he got an initial course of treatment, which he had a very good response from, but he had a little bit of emotional instability, so it was stopped kind of prematurely, but he enjoyed a couple of weeks of incredible well-being that he hadn't experienced before. And with that, because of that emotional instability, we arranged for him to be consulting with a psychiatrist going forward, and then we retreated him with a longer course at a bit of a higher dose than he was on before. And with that, his got a pretty bad neuropathy from the disulfiram superimposed on his Lyme neuropathy, and unfortunately, he was not able to report feeling any net benefit, and he still had to deal with the neuropathy from the disulfiram, which is somewhat better, but it's still not too pleasant. So, he's someone that we didn't really embark on too much in the way of standard antibiotic therapy because he had one short course of oral, and then, we were discussing whether to do, intravenous ceftriaxone or intramuscular ceftriaxone, and that was at a time that we were seeing such impressive results with the disulfiram, and we talked about it very carefully with him and his spouse, and so we decided to do that. Unfortunately, we just spoke to him. My staff just spoke to him recently to try to determine whether he could perceive any benefit at all from having gone through the disulfiram, and he felt that it really was not net beneficial. So sorry.
Off the top of your head, how many patients do you think exist where they got literally zero benefit from the treatment out of the 50 you've tried it on so far?
It's a fairly small number. I mean, out of the 50, maybe there were 3 or 4 or 5 who didn't seem to derive any benefit whatsoever. Most of the patients have reported benefit, and some of them enduring benefit.
And out of those 5 who didn't report benefit, did they ever go on to receive benefit from other antibiotics by any chance?
Well, that person I just described with the neuropathy, he was interested in exploring hyperbaric oxygen therapy, which I had no objection to. I encouraged him to wait a little bit so that we could see what the disulfiram did or didn't do, and he did wait a bit. And then he had heard about hyperbaric oxygen, and he wanted to pursue that, and he actually found a very competent practitioner who did that. He did that for a little while, and then he learned of the work of another practitioner out on the West Coast who had a bit of a different approach, and I think he's pursuing that right now with the use of Alinea, which is not something that is within the scope of what I've used. And I think he's finding that the Alinea is having an impact, but I'm not sure what the net outcome of that can be. The hyperbaric oxygen, he didn't do it that long, so I'm not sure whether that conferred any benefit. But, I think the patients have to find the right help. And, if the right help is me, that's fine, or what I have to offer. And if it's not, if they can't get better with what I have to offer, they definitely should, try to find, whatever venue they can that they can get help and get better.
Yeah, I've actually done hyperbaric oxygen. I did do it while I was on antibiotics as a supplement, and I think, I got some improvement. I felt a little bit more stable, and I felt like I guess you could consider it in remission. But the second I got off of it, within a few months, everything was coming back. So I don't think it was a very effective use of my money personally. But I have heard about the Alinea, and there's some people that seem to be saying good things about their experience with that. But you haven't used it personally, right?
No, well, I did at the patient's request. I did speak to the practitioner who was treating him, and he maintains that the reason he uses Alinea, it's kind of paradoxical. It's not for its anti-parasitic effect, according to that doctor, but he believes that the Alinea is very effective in degrading biofilm, and that's the rationale for it, that was new to me. But so I don't have any experience with Alinea, but I know that that colleagues of mine have been using it, and patients have been reporting that it's been used. But I don't know too much about it, and I don't. Again, there's another area where it would certainly be beneficial if whoever's using it could report on it, in a published fashion so people could evaluate it.
Yeah, that's definitely true. I might try to reach out to that physician and see if we could at some point get a chance to interview him as well. Um, so let's see. I've got a few more things that I want to run by you about the current patients. Do you have any patients? So how many out of the patients that you've done have had to repeat the protocol? Is it just one or two that they did the full 2 months and they had to repeat it?
Yeah, it's a limited number. One of the patients I treated, a very nice young woman who lives in Dutchess County, had definite Lyme, had good evidence of Bartonellosis also, and we really thought that she had babesiosis because of her symptoms and her response to Malarone. And I think she was one of the first patients who I knew or thought I knew who had Bartonella, and I let her know that I didn't have any data on what Disulfiram did or didn't do for Bartonella because the first three patients, as far as I know, did not have Bartonellosis. So for her, she perceived that Bartonella was an important part of her syndrome, and she was most reluctant to go off treatment for Bartonella while she was treated with Disulfiram. And I did not compel her to go off her treatment. So she was being treated with zithromycin and rifampin, and was reluctant to go off that treatment while she was treated with Bartonella. While she was treated with Disulfiram. So in her case, I allowed her to stay on that combination. So that is to say, azithromycin, rifampin, and Disulfiram throughout her course of treatment, and she was monitored carefully. And luckily, fortunately, she tolerated very well, and there were no derangements whatsoever on her surveillance labs. And after, again, she definitely perceived benefit, and her symptoms of Lyme and babesiosis. Again, we didn't prove that she had babesiosis, but clinically, I felt pretty confident that she had it. And she definitely benefited. And I think, if I'm not mistaken, I believe she feels that Lyme and babesiosis are presently non-issues, but Bartonella remains an issue. And I'm trying to think whether she tried going off her zithro and rifampin. And by the way, I encourage you to consult a colleague of mine who does a lot more work with Bartonellosis than I do, and so she's done that. So she's being seen at that practice as well as by me, and so that's one case where you would think that if this were effective against Bartonella, that she would not require ongoing treatment for Bartonellosis, which she does. So it's not a lot of data. It's one patient, but that's why I have expressed that I'm somewhat doubtful that it's an effective treatment for Bartonellosis. But I have some of my colleagues who are thinking that it may have activity against Bartonella for some patients, but I think the jury is out on that.
Yeah, it's pretty safe to say, even if it has no effect on Bartonella, that we should still be extremely excited about this. Just the fact that it works on Borrelia alone is an enormous breakthrough, but having Babesia is just a huge plus. So to expect it to kill all three, I mean, it's a little bit too high of expectations.
Well, I jokingly said to one of my colleagues that, hey, if it knocked out Borrelia, Babesia, and Bartonella, we really would have hit the trifecta, you know.
Do you have a preferred drug to treat Bartonella that you typically see the best results with?
Well, again, I don't consider myself like a super duper expert on Bartonella at all, and there are other people who have a lot more depth in it. But I mean, I use either a tetracycline agent or an azolide. That means either like clarithromycin or azithromycin with rifampin. That's what I usually do. And I know there are other regimens out there. Some people incorporate Bactrim Some people, I know that Dr. Mosiani, who's very, has a lot of expertise with Bartonella, often uses rifabutin. That's a drug that I haven't used. And I think the same thing with Bartonella. There's a lot that we don't know. There definitely is room for improved methods of treatment for that, and that should be a big focus of research too.
Have you heard anything about these two new compounds that there seems to be a lot of talk about? Which one is the methylene blue, and some people, this is kind of more on the fringe and definitely not standardly accepted. Some people are talking about something called gallium nitrate, which I believe is a heavy metal that's given to horses for some reason, but apparently has some benefit on Bartonella. Have you heard of anything about those two?
I've heard people on your Facebook chat group mention that, but I don't actually know anything about it.
Okay. Yeah, the methylene blue seems to have been done by Dr. Zhang at Johns Hopkins. He was the one that did the study on all the compounds that seem to affect Bartonella, but there wasn't a breakthrough.
No, go ahead.
There wasn't a breakthrough compound like there was with Lyme. Nothing was like 100% effective, unfortunately. So there was pretty high efficacy, but no cure in sight at the moment for Bartonella. So it seems Bartonella might end up being even more problematic than Borrelia is. So yeah, if you don't mind, I want to just start moving through some of these questions that we've taken. I went through a few of them with you prior to the interview. Some people asked about whether or not there was any merit to taking it at certain times of day, splitting the dose. Any ideas on that? Whether or not to take it with an antacid, or whether or not to take it on with grapefruit juice, and none of that is something you really have an insight into.
I just don't know.
Okay. And just to be clear, you haven't heard about the effervescent tablet, which apparently is more common in Europe and Australia, from what I've heard.
No, I was not familiar with it.
Okay. Yeah, apparently there is an effervescent option of disulfiram in some places that may or may not be an option for Lyme as well. So what is your current approach with disulfiram, your dose and duration for new patients? Do you have a kind of standard protocol that you follow that you could give a summary of pretty quickly?
Well, again, this is a new agent, a new tool, and I'm figuring out how to use it. I told you about the first 3 patients where I kind of just picked the dose and somewhat arbitrary duration. That first patient, I've been so accustomed to prescribing, long-term antibiotics like 3 months at a clip, so that's why I allowed that first patient to be on the disulfiram for about 3 months. But it depends what's your objective. One objective, obviously, would be to try, if you can, to induce a quote remission, if you can. That's one way to design the treatment. The other is, forgetting about trying to secure a remission. Is there some dosage regimen that, let's say it's a treatment, but maybe not with the aim of inducing a remission, or can you combine the two? So, and also because of that case 3, who just found it intolerable at 500 milligrams a day, and he, on his own advice, he kind of cut the dose and did it every other day. My current general approach for most everybody is to start with a low dose, typically a half of it. They come in 250 and 500. We always prescribe the 250s. Typically a half of a 250, and I've been generally starting out with every 3rd day. That's 125 milligrams every 3rd day. In some people who are very, very sensitive, or there's special reasons that we want to be cautious, like, for example, let's say they have a baseline neuropathy, and we want to be careful not to exacerbate things. I've even started, and again, some of the patients were on another chat group. You're familiar with Christina Pedersen Bauer. Some of the patients have reported using a quarter of a 250 or 62.5 milligrams to start out with, and I think you can't be too careful. So what I was saying is, some of the patients whose condition has been very precarious to begin with, and we wanted to be careful not to push them over the edge. We started with these low doses and were actually amazed to see how potent even these very tiny doses are in securing clinical benefit in some of the patients. So, and this is even in people who are like large people. One of the patients weighed 260 pounds and had a very difficult clinical picture, and 125 milligrams every fourth day only. Within a couple of weeks, he was doing like incredibly better, unbelievably better. Another patient of mine was very, very sick. Those kinds of doses, first of all, using those low doses, you're much less likely to provoke a severe Garish-Herxheimer type of situation. So that makes it more tolerable. And usually there is some, like the first couple of days or week or two, but often after that, the patients were enjoying really improved status, functioning, quality of life. And so it's nice to have like a plan, but I think each clinician and patient really need to individualize the treatment approach. So I don't think it should be like some rigid formula. And also I think it's important that the clinician and the patient be in regular communication with one another, or be able to be in regular communication, because the plan may need to be changed. It's great to have a plan, but you might have to modify it depending on circumstances of whether there's either the patient's experiencing a lot of benefit and you want to stretch out a certain dose for a longer period of time, or they're having toxicity, and then you might have to decide to change the regimen or even suspend treatment if it's necessary.
So you've had patients that have seen enormous benefit even from the 125 every 3 days.
That's right. Every 4 days even. So
every 4 days.
This is this is potent. This is a potent agent. And mind you, I am not using this drug like as a first line treatment for people who've never been treated before. Usually I've been using it in people whose care is problematic and who've already been around the block several times, and gone through all the standard treatments. But then you might ask yourself, well, why go through the standard treatments? Why not use this, right up front? But I'm generally not doing that right now.
Is that just out of being conservative?
Yeah.
Following the standard of
care?
Yeah,
it's out of being conservative, and also, as you don't know what people have when they first come to you, and as I've said before, I don't know whether I made a comment on your group or other groups, that I have no idea what disulfiram does or doesn't do for Ehrlichia anaplasma. So when somebody comes with a new case of Lyme and you don't really know what they have, would I use disulfiram as a first-line agent to treat, Lyme, babesiosis, potentially Ehrlichia anaplasma, God knows what else? I don't think so.
So what would be your go-to antibiotics in the standard acute case?
Well, for a new case, well, a lot of us, even though we know that doxycycline has problems or minocycline has problems, yes, it kills the spirochetal form, but it may shift things into the cystic phase. Still, that's still, I would say, many people would use that when you're initially confronted with a new case of Lyme, maybe someone who's got erythema migrans for the first time, or you think it's an acute case of Lyme. I don't think I'd be brave enough actually to use disulfiram in that setting, even though it theoretically might be superior for Lyme and babesiosis, but I don't know what it would do for the other tick-borne illnesses. So, yeah, I would probably use what would be considered more standard treatment.
Doxycycline.
A lot of people use doxy, and I used to use amoxicillin a lot, So then it became clear, well, amoxicillin, it's great for Lyme. I think it's an excellent agent for Lyme, but it doesn't cover Babesia, it doesn't cover Ehrlichia, it doesn't cover Anaplasma. So although I often will use amoxicillin in patients for Lyme disease, I abandoned using it as first line for a first line agent by itself as a for a new case of Lyme.
I don't know if you saw, Kim Lewis apparently did some studies, I think, and found that vancomycin was probably the most effective antibiotic that was underneath disulfiram, but broad spectrum, the most effective antibiotic against Borrelia. Did you see that study?
Well, I was aware of the work of Alan Barber and one of his collaborators showing that vancomycin has good activity against Borrelia, and I sometimes will use vancomycin, but again, then you're dealing with intravenous agents, and that's more problematic.
Mm-hmm. Yeah, so the best oral was probably going to be doxycycline as your first line of treatment, and then maybe you could consider Bactrim or cefuroxime, or what else? Probably those are the main two that I can think
I don't
of.
use Bactrim for erythema migrans. I don't use Bactrim very much at all, but I know people use it for Bartonella. But I mean, the usual first line agents. The thing is, cefuroxime, it's got the same problem as amoxicillin. It may treat Lyme, but it doesn't treat the co-infections. So with a new case, I think again, many people would use either doxy. I've been I've published the second article in the world literature on using minocycline for Lyme disease, and that, like doxy, would cover Ehrlichia and Anaplasma, but doesn't cover babesiosis. So for an early case of Lyme disease, or even for a tick bite, often I will offer people either minocycline or doxycycline, and then if they want to, realizing there's no published literature on this at all, I would often offer them the option of being treated with Malarone as well, to try to abort Babesia infections. Again, there's been no published literature on using, Malarone as a preventive, as a prophylactic type of treatment. But it seems to me if you're going to use doxycycline, to treat early Lyme, why wouldn't you cover, and that covers most of the treatable tick-borne diseases, or why wouldn't you also offer them treatment with something that you would hope might avert establishment of babesiosis? And again, I'm not aware of any articles in the literature at all that even broach that question, which is kind of silly. You'd think that by this time people would be questioning, can you treat preventively, either for erythema migrans or just for tick bite, to avoid people becoming infected with babesiosis? Nobody's even, I'm the only clinician I know of who would even offer Malarone for tick bite or for early erythema migrans, before the disease is diagnosed or established. And why wait until it gets diagnosed and established when babesiosis can be every bit as problematic as Lyme in terms of eradicating it with our current not very good treatment methods.
So both doxy and minocycline are not able to address babesiosis at all?
As far as I know, they're not effective against babesiosis.
But that you think that those are the best two first lines of treatments, even though they might not be the strongest against Borrelia, but because they have the broadest spectrum of coverage, minus Babesia, they're probably the best option.
Well, that's what I usually offer for tick bite. If people want treatment for tick bite, usually minnow and Malarone for a month or so, or let's see, what was I saying? Or for an early Lyme, erythema, with erythema migrans, I would usually do that initially. And cefuroxime, like amoxicillin, it only treats Lyme, and those are not particularly effective also for either Ehrlichia, Anaplasma, Babesia, or as far as I know, Bartonella either. They're not particularly effective.
Are minocycline and doxycycline basically the same drug to you in terms of their effects?
Yeah, they're very, very similar. To me, minocycline has certain advantages, that it's easier on the stomach, usually not sensitizing, is well absorbed, gets everywhere, including the nervous system at any dose. So I often prefer that. I know some of my colleagues, some of my colleagues actually prefer plain old tetracycline, which occasionally I'll use that in patients. Some of them think it's even superior to doxycycline or minocycline, plain old garden variety tetracycline.
Interesting. So how do you typically ramp up from the 125 every 3 days? Do you go 125 every 2 days, or do you eventually just go straight from 125 every 3 days to 250 every 3 days?
Well, I've been doing it gradually with the idea of trying to make the treatment as tolerable as possible for the patients. And that slow ramp up does make it tolerable. But then I wonder, what's the best approach? I actually don't know what the best approach is. If you do a very gradual ramp up over months, let's say 125 every third day, then 125 every other day, then 125 every day, and then you go the next level, 125, 125, 250, and you kind of, so 125, 125, 250, and then go 125, 250 alternate days, and then 250 every day. And by the way, I'm usually giving people, 10 days to 2 weeks at any given dose to let the drug equilibrate before ratcheting it up. But that does can depending on how slowly you do it. And some people even say, oh, do 125, 125, and then 125 plus a quarter. So that would be 185 something or 187 or whatever. You can also drag it out. And then the question is, how necessary is it to be that gradual, and should you, do it more quickly? Also, well, then you're exposing the patient to the disulfiram over a longer period of time. And is that going to result in more toxicity than if you just, sucked it up and started at a higher dose right at the get-go and got it over with in 6 weeks or something? Or, I don't know the answer to that. What is actually the best approach? I'm not sure. With antibiotics, typically I'll kind of gradually ramp it up. So that's a similar approach I'm adopting with disulfiram to make it tolerable. But then, are you going to end up with more toxicity because the patient's on the drug for a longer period of time to get up to the full dose? And then, but anyway, my general approach for most people would be to start slowly, ramp it up over a period of time, which could be even a couple of months to get to what I call target dose. And I'm trying to figure that out, what that target dose ought to be. I'm figuring that it should be, like most drugs are usually based on, dosage per weight. And then once you get to that target dose, then have the patient on it somewhere between 6 and 12 weeks. I'm not having anybody on a quote target dose or full dose more than 12 weeks so far, and then suspend treatment and observe for a period of time and see, how they do, and realizing it takes at least 2 weeks for the drug to wash out. And then I think you really need a period of equilibration of probably a couple of months to really know where you are and what you have or haven't achieved.
Interesting. So does it sound like you typically go from 125 every 3 days after 10 days or after a month to 250 every 3 days straight, or do you go 125 every 2 days every single day and then go to 250?
I usually have a discussion with the patient because some people are eager to ramp it up sooner rather than later. If one wants to be gradual, what I've been doing is 125 every third day, then 125 every other day, then 125 every day, and that can stretch it out over a number of weeks, of course, and then going to 125, 125, 250, and then for a while, then 125, 250 alternate days, then 250 every day, and then work it up that way. Is that too gradual? Could you do it more quickly? Again, I don't claim to have this all worked out. And also, I'm usually proceeding in a what I call a consensual approach with the patient, letting them know what my experience has been, letting them know what I don't know, and then so we're figuring this out as we go along. And also, Uh, I'm learning not only from my own patients, but I'm also learning from, what the experience of the patients who are in your group and in some of the other groups. Again, we're all kind of learning together, and I'm trying to, provide my insights, but I'm also very much learning from the patients, and many of the patients are posting some excellent articles from the literature, some of which I wasn't even aware of, um, and it's definitely a learning curve.
How often do you have to pause the treatment in the middle of it, and what would be the symptoms or the reasons that you typically pause?
Um, well, I wouldn't say so much to pause as to suspend treatment if we think the patient is experiencing significant adverse effects, like if there's emotional instability or they're clearly developing a neuropathy from the treatment that's distinguishable from their baseline neuropathy from Lyme. It gets to be a judgment call, and where you have to weigh risk versus benefit. And, you know, if you think that the course of disulfiram may be able to induce a remission, is it worth it to um, risk sustaining some neuropathy from the disulfiram if you think at the end of the day there'll be a net benefit if you can induce remission, and realizing that in many instances, but I can't even say every instance, the the disulfiram induced neuropathy improves or resolves once you discontinue the agent. Um, it's kind of a judgment call, and in that situation, I usually like to engage in what they call shared decision making with the patient, realizing that there remains a degree of uncertainty. You know, um, it's not all cut and dried.
Okay. So you typically either suspend permanently, you don't typically break for a few days and then resume.
Well, you might if it seems like it's not really an adverse reaction, but the disulfiram is provoking too intense Herxheimer, for example. Certainly, yeah, you might want to suspend and then resume more slowly, for example. That's a little bit different than having a clearly toxic or adverse reaction where you definitely want to suspend. Uh,
Have you have you seen anything where just so patients are aware in the group if there's any types of experiences or reactions that you would think are justification to immediately stop? Is there anything that you might want to warn people about if anything happens to them that they should be
yes,
aware of?
I had two patients who had modest, but enough of a liver dysfunction situation where their liver function tests were high enough, and not only that, but on exam, and one of the patients, um, when you examine patient's abdomen and they take a deep breath with your hands folded over the ribs, and that caused discomfort, what they call a positive Murphy sign. It's a it's a it's a it's a term that people use often when you're evaluating people for gallbladder symptoms. If they take a deep breath and your fingers are over the ribs, and when they take a deep breath, it induces pain. So that was one particular patient where not only was there, again, these liver enzymes were not dangerous in themselves, but they were elevated enough that it got my concern. And then on top of that, the person has a positive Murphy sign that definitely, and they happened to be towards the end of their course. You know, they'd already exceeded their sort of minimum recommended duration at full dose. So we were at a point where we were deciding, well, should we go, you know, I forget where they were. Maybe they were at 6 weeks or eight. I think they were 8 weeks, and we were trying to decide, well, should we be 10? Should we do 10 weeks? Should we do 12 weeks? And that was a decider. That was time to stop. And those liver function tests, resolved. Um, so that's one example. And I am following liver function tests very, very carefully, especially early on, um, because some of these reactions can be But luckily in our cohort of patients, we've not seen any serious liver injury. But yeah, from the literature, you can see that there are these rare cases of very severe liver injury, and you don't want to miss that. Um, and you know that it takes at least 2 weeks for the drug to get out of the system. So and even if you stop it, it doesn't guarantee that there might not be ongoing injury, for a while. So that would be one.
How how
Sorry.
frequent how frequently do you test liver enzymes once someone starts the protocol?
I give them a standing order for up to weekly general labs, which includes liver function tests. So I've been having patients check at the end of weeks 1, 2, 4, and then every 2 weeks thereafter, which maybe that's overkill, of the testing, but I'd rather, again, considering this is novel, a novel, use of this agent, I would rather be safe than sorry, and I think you can't be too careful. And maybe that's excessive, every 2 weeks after the first month, but um, and the patients are not always compliant in getting it as frequently as I would like, but and knock wood, in these first 50 patients, we have not seen anything, dangerous, life-threatening, no irreversible injury. But we're very mindful of that potential, and that's why since we had this result, a dramatic favorable result, and I prepared this manuscript, I felt obliged to scour the literature and include in the manuscript as a warning to patients and those clinicians who might use disulfiram to be very aware of the potential adverse effects, some of which can be quite serious, so that hopefully they can see it coming and discontinue treatment before some irreversible injury has occurred.
See, the only two patients that have had elevated liver enzymes were at the later time in their course, right? In the
Yeah,
late
let me
stage of
just
their
say
course
that
of treatment, right?
overall, with all of this monitoring that I've done in these patients, I'm impressed with how benign this agent is overall. It's been very well tolerated by most people, and we we have hardly seen any derangements on these labs, with rare exceptions. And but obviously, it's important to do this monitoring.
The main three side effects that people are concerned about are liver damage, which we just discussed. You've only had two patients that had elevated liver enzymes, and that went away, and they seemingly had no
Correct.
lasting problems, right? So liver damage hasn't been an issue for you at all. What about the neuropathy side effect? How common have you seen that, and has it reversed in all
Yeah, I mean
cases?
that's common enough that it's gotten my attention. It's still not that many, maybe 10 or a dozen patients, but it's enough that it made me want to research more what the mechanism is, number one, and also made me more mindful of um, being conservative in the dosage that I use and trying to adjust the dosage for weight in an effort to minimize the neuropathy, and also to be mindful that duration as well as dosage may be important. And that's why I'm questioning myself, well, are you better off ramping it up over many months and then getting to the target dose, and so the whole course of treatment is longer? Or would you be better off just hitting people with a full dose, realizing they're going to have significant Herxheimer's and have to be limit their activities or have support, and get it over with, and not drag it out? Is what's the better strategy? And at this point, I'm not sure what the better strategy is.
I mean, I can say firsthand, when I first treated my Lyme with doxycycline, I had severe neuropathy develop. So how can you be sure that out of those 10 that they're all suffering from neuropathy due to the drug's side effects rather than due to the Herxheimer itself?
You mentioned doxy. Did you mean doxy or did you mean disulfiram?
I meant
Oh,
doxycycline. When I first got diagnosed in 2016, that was my first treatment drug as well. And I had extremely severe neuropathy develop throughout the body. I even had my teeth go numb.
Huh.
So, I'm just wondering if that had happened to me on disulfiram, I could have easily been saying, "Oh man, like this has just ruined my nerves." That took months to recover from, but it eventually all
That's
reversed.
interesting.
Hmm.
I don't know. It seems to me that for people who, well, that's a good question. Did the disulfiram provoke neuropathic symptoms because it was really a kind of like a Herxheimer of Borrelia in the peripheral nervous system that the drug provoked versus strictly a disulfiram-induced neuropathy, which is quite different. That's a good question. But I mean, I told you about that one patient who had a well-established neuropathy from Lyme, and then, well, I guess that's a good question. Is the neuropathy that it provoked disulfiram neuropathy, or was it just a provocation of his pre-existing Lyme neuropathy? That's a good question that you raised. Had to raise.
I mean, my neuropathy was definitely in the standard areas like the legs, throughout the body. So I could imagine easily thinking, "Oh, this is a side effect of disulfiram." And I just wonder, 10 out of 50 seems fairly high. That's what, 20%. And if it were 20% of people developing neuropathy with the drug, you would think there would be more evidence in the literature saying, "Hey, this is an extremely common side effect." Which there doesn't appear to be anything saying that, from my understanding. Is there?
I think there's quite a few articles on neuropathy induced by disulfiram in alcoholic patients. There's a sizable literature.
But do you think the frequency is anywhere near 20%? That seems very high to me.
I don't know the answer, but again,
Okay.
because I was seeing that, and it seemed to resolve when the disulfiram was discontinued in most of the patients. I'm assuming that in many cases it really is disulfiram related and not just some type of a Herx affecting the nervous system. People who maybe had a subclinical neuropathy that was provoked by the disulfiram that was Lyme related. Again, this would really require careful study by people who have expertise in evaluation of peripheral neuropathy.
But is the understanding of the mechanism of action that somehow the copper is being chelated out of the body and into the nerves potentially, or into the blood, and then it's potentially damaging the nerves temporarily? Is that the
Well,
understanding?
there were a number of articles posted just this morning on your group by one of the patients that raised a lot of potential different mechanisms. But after I was seeing that, I did some research and came across a series of articles out of Vanderbilt that was taking the position that the peripheral neuropathy related to disulfiram was due to one of its breakdown products, something called abbreviated DEDC. I forget what that stands for. Diethyl disulfide carbamate or something like that. I may be wrong on what that stands for, but that binds with copper, and that combination, the DEDC copper combination, um, migrates because it's lipid soluble, migrates into the nerves, bringing with it the copper, and they asserted that it was the copper per se that was damaging to the myelin in the peripheral nerves, and also that DEDC copper also migrates into the central nervous system, and that they were stating that it was the copper that damaged the myelin, and that when you discontinued the disulfiram, that eventually leached back out of the nerves, and enabled the nerves to recover. Um, and that series of articles also pointed out that the washout from the central nervous system of that DEDC copper um, um, was much more delayed. So, and then you have to wonder some of the toxicity that people experience, and even the neuropsychiatric symptoms. Is it related to the effects of disulfiram on neurotransmitters per se, or does the DEDC copper itself produce some type of neurotoxicity that's separate and apart from strictly neurotransmitter-related neurotoxicity? These are good questions that I don't know the answers for. And also, there may be other mechanisms of the peripheral neuropathy besides just, you know, the one that the Vanderbilt group identified.
But it would probably be safe to say that one should not be supplementing with copper unless medically advised while you're taking this drug.
I would imagine. Not.
Sure.
Again, I don't know what to say about it. I know patients are raising all kinds of questions, or they're doing different things in an effort to minimize the toxicity. But I don't know if that's advisable, and whether it be a good thing to do or a bad thing to do.
Okay. But the psychosis is the other major side effect that people have been concerned about. And from your understanding, the psychosis is not necessarily caused by the copper, but rather how it affects dopamine in the brain.
Right. The main argument has been that disulfiram inhibits dopamine beta hydroxylase. And again, one of my colleagues who was like hysterical about how dangerous disulfiram is and how everybody would end up in the loony bin, to try to persuade me of that, did a literature review between 1996 and 2016, and came up with a total of like 8 reports in the literature of disulfiram-induced psychosis. And so, you know, not that every case gets reported, but that sort of ended up countering his argument, because that's not a lot of cases, but certainly it's, you know, within the realm of what can happen with disulfiram. We in our 50 or so patients, we had one patient who developed sort of a hypomanic state that was of enough concern to that patient's mental health practitioner that they contacted me, and again, the patient had already been on treatment for a while, and we agreed that was a definite indication to discontinue it, and things did clear up. We've had a small number of patients experience what I'm describing as a poorly characterized state of emotional distress, not psychosis, not depression. There's an element of anxiety, and again, it's a limited number, but I'm beginning to kind of perceive a sort of a syndrome related to disulfiram use, which again sort of mandates that you discontinue the treatment. It was not psychosis, but it was a uncharacteristic for these patients' state of emotional distress that I'm pretty convinced is related to the disulfiram and would be a reason to discontinue it.
Permanently, or just
certainly
maybe consider a lower dose?
Certainly for that go round of treatment, because it can take a while for that to clear from the system, you know, and it might be even more than 2 weeks, you know, to clear from the central nervous system. So I think it kind of mandates. One of the patients that happened, and that person took a break and then resumed it, and it didn't go well on the resumption, and we both concluded that person needed to, you know, discontinue it and take a good long break and before considering resuming disulfiram.
You're a traditionally trained psychiatrist,
no,
right?
I don't have a back. No, I don't have
oh,
a
you're not?
In psychiatry.
For some reason, I was told you were a psychiatrist, but you're just an MD, right? Not a psychiatrist.
Well, yeah, I need psychiatrists or MDs too, but no, I don't have any separate training in psychiatry.
Oh, okay. I wonder why I was misinformed about that. So, do you think there's any merit if someone is already predisposed to psychosis, and this is being caused by the fact that disulfiram is blocking the breakdown of dopamine, to potentially take a dopamine inhibitor to counteract the buildup of dopamine that might be caused by this drug?
I'll put it this way. I think it's overkill to have every patient going on disulfiram have a psychiatric consultation. It seems like not warranted. On the other hand, if the person already is dealing with psychiatric issues, um, it might not be a bad idea. Um, well, they're probably working with the mental health practitioner anyway if they're having those issues. Um, but it might be in individual cases prudent to have the patient consult with a psychiatrist in advance of starting disulfiram. Oh, that's another thing I wanted to mention. Because this is a novel use, even though it's an FDA-approved drug, my own um, way of functioning is to, before I ever prescribe disulfiram, I have a sort of a boilerplate letter which I modify for each patient, and I ask the patient to provide me with the full contact information of all the important clinicians and physicians or other practitioners that are involved in their care, and I send out a letter to those practitioners in advance of actually prescribing so that they are aware of what we're doing, why we're doing it, and also so that they're informed so that they can be, vigilant in case there's anything, that's adverse that's happening. And it's probably not mandatory to do that, but I think it's probably a good thing to do given that this is novel. And also if the patient does have an adverse reaction of one kind or another, and you know, it, it's not really fair to the primary care physician to embark on this and then have a problem and then inform them after the fact, instead of informing them in advance. So that's what I do, even though it is time consuming and a bit more effort. I think it's a good procedure to follow, and it's a good practice of medicine anyway to inform the other practitioners involved in the case. And that's
Yeah,
what I've done
absolutely.
throughout.
That makes a lot of sense. But is it to be just to be clear, is it the dopamine breakdown that's being blocked by disulfiram?
I'm not a psychopharmacologist. One of my colleagues, um, Jane Mark, I don't know how many people know her, Marke. She's in Manhattan. She's very, very bright, and she's been very involved in the Lyme endeavor. And she's she's I don't know whether it's on your group or she and I are in another group, which is Dr. Robert Bransfield's chat group, MMI. Are you familiar with that? It stands for Microbes and Mental Illness. I know she's posted there with her, thoughts about different mechanisms of action. So again, I'm not a psychopharmacologist. It's sort of outside of my skill set, but I'm not even sure exactly what the mechanism. My understanding is that a lot of neuropsychiatric issues were related to interference with dopamine beta hydroxylase by disulfiram.
Okay. I just wanted to make sure because I wasn't sure if it leads to excessive dopamine or a deficiency of dopamine, but it sounds like it's an excess of dopamine,
I'm not
right?
the right one to ask.
Or you're not sure? Okay. Because when I first did my first experimentation with disulfiram, I actually started out very early on when there wasn't information on the dosages, and I started out pretty high, I think 250 a day, and I was also not really sure about I didn't realize the topical alcohol containing products could potentially be an issue. So I was still using a few of those, and I think I might have even used an alcohol containing tincture once, and all I know is that I was basically bedridden. I couldn't really do anything, had very low motivation, low energy, and I thought that if anything, my dopamine seemed to be down, not up, because typically high dopamine is what you get from something like cocaine or methamphetamine, and you'd get a lot of energy, not a insufficiency of energy. So I definitely went the other direction, but that may have just been a side effect of the acetaldehyde,
Well, you might.
which is one of the other things
Yeah,
I
it
wanted
sounds
to
like
bring
you
up.
might have been having what they abbreviate it. They call it a DER, disulfiram ethanol reaction. And that's another thing. I don't know what to say about supplements and herbs and whatnot, but a lot of the herbs are in tinctures of alcohol, so obviously those definitely have to be eliminated.
Right. Yeah, I described myself as feeling like I was drunk partially. I would get up and I'd kind of stumble a little bit, not very solid and on my feet. So I definitely think it was probably the alcohol related. So how extreme do you recommend patients go as far as avoiding alcohol? Like, is it anything topical as well as anything oral with alcohol you suggest avoiding?
Well, obviously, any ingested alcohol for sure. Um, um, some of my patients have reported even, they may be very sensitive, but even getting a skin swab for blood draw with isopropyl alcohol, they reported having a mild, DER, they say. And then some surprising things have come up that you wouldn't have expected or wouldn't have even been aware of. But one of my patients apparently experienced a disulfiram ethanol reaction after eating a slice of pecan pie, which was surprising. But then it turns out that pecan pie has molasses in it, and that at room temperature, that molasses can ferment. Um, so, like things that you wouldn't expect. Um, so
Interesting. What's your take on some of the acetaldehyde containing foods like coffee and
I
chocolate?
don't know.
Mm-hmm. Okay. So you don't have patients that are saying anything good or bad about those in with their experiences.
Well, I think people are they're trying to
Yep.
avoid fermented foods, and I guess vinegar can have some alcohol in it, and people are pointing out that a lot of condiments, mustard, can have some alcohol in it. So again, it's a learning curve. One of my patients went out to a pub, but not to drink, and had a shepherd's pie and had a pretty significant disulfiram reaction. He reported, and then he told me that in shepherd's pie they often use Worcestershire sauce, and I don't know. I gather that has alcohol or some products in it. So I don't know. It's you do what you can to avoid anything with alcohol, and
Just so patients are aware in the group, what are the typical signs of the disulfiram ethanol reaction that they should be aware of?
they just feel fairly quickly just horrible. Nausea, vomiting, headache. The severe disulfiram ethanol reaction can be life-threatening. Take a sizable amount of alcohol when you're on disulfiram. So, it can drop your blood pressure. I guess there are reports of people, because their blood pressure is dropping, even having myocardial infarctions, their blood pressure is so low. So,
Oh, wow.
yeah, I mean, it's good to know how that presents. And I mean, there is a whole emergency type thing of what you're supposed to do if you have that. But the main thing is to avoid it in the first place. I guess if it's bad enough, go to an emergency room and know what's happened.
So if they do find themselves in a situation where they accidentally ingested something containing alcohol or acetaldehyde, you suggest if it's getting bad, go to the emergency room. But if it's not, is there anything that they can do to help offset it if it's a more mild situation?
I'm not sure. I mean, obviously, you'd go to the emergency if the condition was so severe that it was alarming, But
Right.
I mean, I'm sure if you go to the package insert, there's a recommendation of things to do if you experience it. I've not been faced with something that severe. The main thing is to avoid it, obviously, going forward, or maybe suspend your disulfiram when you're going. Don't take another dose of disulfiram if you're going through it.
Don't you find it interesting that after, I think it's something like 7 decades of use, that they didn't realize this drug had any effect on Borrelia at all? After how many tens of thousands of people have used it around the world, which I'm assuming many of them had Lyme disease and probably had to stop the treatment because they probably had such bad reactions. In some cases, I'm assuming.
Yeah. Well, that raises an interesting question. Could somebody do a retrospective analysis of people being treated with alcoholism who had Lyme disease? One of my colleagues was telling me that one of his patients who was using disulfiram to treat their alcoholism, and the patient was having just an incredibly difficult time handling the disulfiram, and then it turned out that the psychiatrist figured out later on that the patient actually had undiagnosed Lyme disease, with their alcoholism. Um, yeah, that would be an interesting thing to look at.
Yeah, I have to assume that the patients who unknowingly had Lyme that was untreated, undiagnosed, probably failed to stay on this treatment because they reacted poorly to the drug and said, hey, this is just not for me. I'm assuming that's probably what happened with many of them. And then I'm assuming there's a handful of people who maybe made it through who had previously been treated for Lyme but hadn't cured it, and maybe they ended up curing it and didn't even realize they had cured it. And that just seems remarkable to me that no one else ever noticed anything and never commented about their reaction to the drug with Lyme disease. I guess it's probably not that common that you're on the drug for alcoholism and that you have Lyme disease and know it at the same time.
My understanding is people who are being treated with disulfiram for alcoholism um, usually handle the drug pretty well, unless they drink. And as a matter of fact, I have a family that I'm caring for, and one of the family members actually, and all the family members have Lyme, and one of the family members also had a problem with alcohol, and was treated with disulfiram on a number of occasions for the alcoholism. And of the three family members, that family member is doing best of all the three, and this is before anybody knew anything about disulfiram and Lyme. It's kind of interesting, a little anecdote for what it's worth.
Interesting. What is your standard? Do you have a milligram per kilogram dose that is your target calculation for individuals?
It's very, very rough, but I'm figuring, why would you give somebody who's 100 pounds the same dose as someone who's 200 pounds? So in my simple-minded way, okay, it turns out that 500 milligrams a day for a 200-pound person seems to be, pretty appropriate. So for a 100-pound person, I'm thinking, maybe 250 should be the maximum dose. And for, then in between, maybe 150-pound or 140-pound person, maybe 375. So again, it kind of ranges. But again, because of what I've seen with the peripheral neuropathy, there was a time where I would give people, maybe 250, maybe 500, and I've seen some of my patients, like I have one patient who's 140 pounds, where giving them that leeway to go to 500, and as you know, patients with Lyme often are very zealous about trying to get rid of the infection, and they are happy to explore the higher dosages, and then I'm realizing, whoops, they're more likely to get toxicity with those doses. So that's made me rein in the doses a bit.
Is there any case where exceeding 500 milligrams would be recommended? Probably not, unless they're.
Yes. Well, one of my patients was on. Trying to think here. Trying to think of what the circumstances were. Weighed 230 pounds, and I don't know if we did if we did 500, or we might have done 750 a day for that person, and they did well and then relapsed, and I think we did either 750, or we might have even, if we did a gram. I think we might have done a gram. That's the highest dose I've ever used, and they were doing well, and then like overnight they developed severe neuropathy, and it wasn't like it came on gradually. It was very, very abrupt, and of course, they discontinued the treatment, and the neuropathy was really pretty problematic, and we needed to prescribe gabapentin in fairly good doses. But the neuropathy was bad, but that's been resolving. But otherwise they were doing great in terms of their symptoms. And this is another person with Lyme and babesiosis, who was doing extremely well. except for the neuropathy. But the neuropathy was very, very alarming, and it was again, it didn't kind of gradually come on. They were handling the dose, and then it came on fairly abruptly. So we didn't really see it coming, but clearly when that happened, they very shortly discontinued the dose. But they've been doing actually very, very well otherwise, other than that.
Interesting. So, do you have a way in these types of cases? Because I have one person who asked this question to differentiate the side effects from the drug from the actual side effects of the Herxheimer reaction.
Well, again, this was in a patient who did not have any significant neuropathic symptoms, from her Lyme. So it seemed that it seemed to be induced from the disulfiram.
Okay. Welcome back, Dr. Liegner. We were just wondering, where are there any symptoms that you can describe that patient experienced in regards to the severe abrupt neuropathy, just so patients are aware of what to look out for?
I think it was a severe. I think it was a severe burning type of discomfort, and this is a person who's not a wimp, and it was quite alarming to
Okay.
her.
And does that overlap with the other type descriptions of disulfiram-induced neuropathy that you've heard from other patients? Those symptoms, burning, does that seem to be the common one?
Yeah, I mean that's probably the most distressing because it's painful, you know, and that is improving after she stopped the drug. So it's not completely resolved, but it's improving. And like I said, her other symptoms are, she's doing actually, aside from that, she's doing very, very well. And we're hoping, it remains to be seen, that she'll be able to enjoy a more enduring remission.
Okay. I'm just curious if you found yourself to be infected with Lyme disease in the early stages, would you just use a traditional antibiotic like Doxy, or would you combine it with disulfiram?
I don't know the answer to that.
Okay. Do you ever use herbals in any of your treatments of Lyme patients? Herbal remedies as a supplement?
I'm not trained in herbal approaches. I have nothing against it, and in fact, I admire the work, for example, of Stephen Booner, who's very knowledgeable. He's a master herbalist, and he really knows Lyme a lot. I was influenced by the work of Dr. Richard Brown in the book that he published. Uh, it's related to ginseng. Blocking on the name, but yeah. So occasionally, but I'm not really very well versed with herbals, so I leave that to other people. And if people want to pursue that, I usually encourage them to work with somebody who has more deep experience with herbals. So like some of the naturopaths are very well trained in that. And I often mention to them the Stephen Booner's books, starting with Healing Lyme, with his herbal approaches.
So, are there any supplements or foods that you recommend to help deal with the Herxheimer reaction by any chance, or not really?
Not really.
Okay. This is a question about the safety and side effects. What markers outside of the liver enzymes do you typically test for, and how frequently do you test for them besides the liver one?
Well, I have a sort of a standard set of quote what I call surveillance labs, not just for disulfiram, but for other treatments, and that usually consists of a complete blood count, liver function tests, which consist of AST, ALT, GGT. That's important because not everybody gets the GGT. Total bilirubin, BUN and creatinine, and CPK, and a urinalysis. That's usually what I consider my quote minimal surveillance labs. And sometimes if everything else is fine, but it's just the liver function test, sometimes I'll give patients a standing order for just liver function tests alone, so as not to do the other things where there's not a problem.
Do you continue those testings throughout the entire duration of treatment, or only a couple times in the beginning, all of those?
I do it throughout.
Okay, interesting. Um, my next question is, how many patients have you seen that have issues with acetaldehyde from foods taking disulfiram?
I don't know the answer to that question because I don't query patients about acetaldehyde in their foods.
Okay. Um, and what are the most common major side effects you're seeing with your patients, if any?
Well, a lot of people do experience Herxheimer type reactions, and that's another reason why I found it, desirable to introduce this much more cautiously and gingerly, and then gradually build it up. Um, some patients tolerate it, pretty well. Um, but I guess many patients do report significant Herxheimer's, and also a lot of the patients have reported again, tried many different kinds of treatments. They're very impressed by the potency, or what they perceive to be the potency of disulfiram compared to other treatments that they've received.
One member of the group was asking if having a sulfa allergy is an issue for disulfiram use.
Well, you would think that disulfiram would be a sulfa drug because of the name, but evidently it's not. Structurally, it's not a so-called sulfa drug. It does have two sulfur atoms in it, but it's not a sulfa drug as far as I know. And I have had patients who have had sulfa drug allergies who have not had any problems whatsoever with disulfiram. But obviously, that is a question that should be addressed by the patient to their physician, and if necessary, running it by pharmacologists and or pharmacists.
Are there any telltale symptoms that are side effects that you would say are definitely caused from disulfiram and that are not likely to be attributed to the Herxheimer, or vice versa, signs that are definitely Herxheimer and not likely to be attributed to the disulfiram?
Well, I think you'd have to be vigilant for any of the things that one might see with a major drug reaction. You know, unusual rash, or breathing difficulties, hives, or you know, the, or dropping of blood pressure precipitously. That would be dangerous. Um, that would be distinguishable from Alzheimer type effect.
Okay. A couple of questions. One person was asking, does disulfiram have any impact on thyroid by any chance? Thyroid function, thyroid metabolism, or glucose metabolism? That was another question, to your knowledge.
I don't know the answer to those questions, not that I'm aware of, but I haven't specifically looked.
One person asked what to do if optic neuritis develops. I'm not sure if you've ever heard of that. If that's very common.
Yeah, well, there's something called the toxic optic neuropathy from disulfiram, which I actually was, that's kind of alarming, to the idea that it could be a toxic optic neuropathy. And I did try to look into that more depth, and wanted to get the original articles on it, but I couldn't find that much information. Obviously, you would discontinue the drug right quick and seek ophthalmological consultation without delay.
Okay. Um, have you seen people having mood changes from this drug by any chance?
Yes.
And are anything you care to share about what types of mood changes?
Yeah. Um, I've seen a couple of patients have had mood disturbance. One patient was, just a little bit paranoid, nothing dangerous, but that was a reason that we discontinued the drug. I had another patient who developed a sort of a hypomanic state, which was not her usual baseline. It was not exactly maladaptive, but it really wasn't normal for her, and that influenced us to discontinue treatment. I've had a number of patients develop not very well characterized state of emotional distress that seemed to be related to the drug itself. It wasn't psychosis. It wasn't maybe it was sort of an anxious state, or a mild agitation, but they perceived it definitely was normal and it was alarming to them. And I definitely think it was related to the disulfiram, and that was a reason to suspend treatment in their cases. Uh, I told you that case one, it required psychiatric hospitalization, but we're not sure if it was from the drug or not. And I never heard him use the word that he was psychotic or anything like that. So um, we have not seen anyone who had a who that I know of that where the use resulted in a psychotic state in the 40 or 50 or so patients that we used it in. But again, we're very mindful of that possibility.
Okay.
Um, so,
One person who has mast cell activation syndrome was asking whether or not disulfiram might make things worse for them, or whether or not you have patients with mast cell activation syndrome that you're treating by any chance.
yeah, that's an excellent question. And again, I think there's not that much data on it. Um, and just trying to think. Yeah, and I know that there are some who feel that mast cell is quite common in the or overlaps quite a bit or can be present coincidentally in patients with Lyme, and that's a concern too because the disulfiram has such a long activity. It's not like a drug where you take the drug and the drug is out of your system, in a day or so. Disulfiram, even if you take a small dose, it's in your system for like 2 weeks. So what would be the consequences if it did trigger, you know, um, a mast cell activation syndrome? That's another area where there's not that much data on, and I don't have too many patients right now that I know have mast cell activation syndrome for sure, or who are um, actively working with a mast cell activation specialist. And as you probably know, getting in with someone who has expertise in mast cell activation syndrome is way harder than getting in to see a so-called Lyme literate physician. And there's not that many people in the country who do that. I'm fortunate that I have someone um, who's actually fairly close to my office who's got world-class reputation with mast cell. And thus far, we have not yet uh, had a situation where a patient is actively working with that practitioner while they're working with me. But it certainly crossed my mind that it's a reason to proceed with care, special care, somebody who has that, because you don't know what the impact of that's going to be on mast cell.
Yeah, I actually do. I actually have mast cell activation syndrome myself, and I've seen
Mhm.
Dr. Afrin. Is that who you're talking about by any chance?
It is.
Interesting. Yeah. Yeah, I took disulfiram. I didn't personally have an issue with any of my allergy symptoms noticeably from it, but I had a lot of symptoms that I get from treating Lyme from it.
Uh-huh.
So another question was, is there any known effect that you know of on the gut microbiome from taking disulfiram versus an antibiotic? Obviously, I'm assuming it's not as harsh on the gut.
Yeah, I mean, well, disulfiram has a lot of antibacterial activity, aside from Lyme. Um, I have not made it a habit, nor has it seemed necessary to insist that patients on disulfiram take probiotics as they would with the use of antibiotics. And so I don't even recommend probiotics per se, although I'm not against it if people want to use it. But it hasn't seemed necessary. I haven't had any patients develop either yeast infections with it or have anything that seemed remotely suggestive of C. diff. So that's another advantage of it. It seems that people don't need to go out and buy probiotics, which they can get expensive too.
That actually leads me to a question I kind of wanted to ask earlier. Have you had patients who have candidiasis or at least some level of candida buildup in their gut that have had problems with this drug? And do you suggest eliminating candida before starting disulfiram?
It hasn't really come up too much of an issue, but if I'm not mistaken, disulfiram is purported to have anti-candida effects itself.
Yes, that's true. I have heard that. Have you seen that clinically as well?
I haven't really focused on it.
Interesting. Okay. Um, a couple of people were worried about dental amalgam fillings and whether or not that's whether or not having mercury would be a problem in their system with taking disulfiram.
That's an interesting question too, because I recently had a young woman come to me that we were all set to do disulfiram, and then she had been to another practitioner prior to me who had documented on a standard blood test a very high level of mercury. And I actually was not going to allow her to use disulfiram. And then I repeated the blood mercury level, and it was normal. So it became a non-issue. But if it's true that disulfiram, chelates metals, which I guess it is, and then you've encountered somebody who has a very high blood mercury level, are you going to damage them by dragging that mercury into their nervous system along with the disulfiram? It certainly gave me pause, and I actually probably wouldn't have prescribed disulfiram had we confirmed that she actually had a high, blood mercury level. I probably wouldn't. I probably would have suggested that she consult somebody who deals with with uh, mercury toxicity and get that resolved before. I mean, that's just. I don't even know if that's necessary, but it would have made me very circumspect about using disulfiram in somebody who had known pre-existing heavy metal toxicities or active.
Yes. So apparently the fact that it's a chelator of copper means that it may also be a chelator of it's also a chelator of other metals, we think, right? At least a weak
Yes,
chelator.
I mean that's what the literature said, that it chelates a lot of different metals, not just um, mercury, not just copper.
One of the patients was asking, is there anything that you do to help mitigate the effect of copper toxicity?
No,
Okay.
I don't know how you would do that or whether that's necessary. And I mean, copper is a normal, it's a normal element to be found in the body at a certain level.
Do you have any detox protocols or methods that you generally recommend for patients?
Not my thing.
Okay. If a patient has a very severe Herx to disulfiram, how do you typically handle that?
Suspend and then reduce the dose and/or frequency. So there's some patients we're using as little as 125 a week, or special circumstances even 62.5 milligrams a week, just to start out with, just to make sure that they tolerate it.
Out of the patients who have seen improvement, how long does it typically take for them to notice improvement into their treatment? And what dosage levels are they typically at when they notice things changing? Does it vary?
Well, it's a little bit different than antibiotic usage, although, like I told you, some of the patients on these very small doses reported feeling really better, and not just feeling better, but their functioning greatly improved. But it hasn't really been the idea of you get better on the treatment, and that's how you know it's working. A lot of times, the patients feel better only after they go off, because of like that second patient I told you felt really horrible. He was really debilitated on the treatment, and it was only after the patient. And so that's what I'm seeing in some of the patients. It's not so much how they feel on the treatment; it's how they feel after the treatment is over, and the drug is out of their system, and they can assess what impact the treatment has had on the infection or infections that we think it's working against. So it's a little different than antibiotic usage, which is sort of like we've had to do often open-ended treatment. And then the goal there is to, find a regimen or a combination on which the patient is feeling consistently well. It's a little bit different strategy that with the disulfiram. It's a little bit different. It's not, you're not always aiming to get them feeling well on the disulfiram. It's get them the necessary course of disulfiram that you think or you hope is sufficient to either knock out, if that's possible, and again, I'm not even claiming that I know it's a cure, or knock down the infection so that they can enjoy a period of well-being without need of further antimicrobial or disulfiram treatment. So it's a little bit different. Are you there, Harrison?
Oh, sorry, my microphone was actually muted. I'm sorry about that. I had another question from someone in the group about the ketogenic diet. I'm actually a patient that's also using the ketogenic diet to pretty good success. I've had noticed a reduction in my brain fog and brain inflammation and increased focus and concentration. I was just wondering whether or not there's any contraindication to the ketogenic diet or being in ketosis and DSF usage.
Don't know the answer to that.
Okay. And let's see here. So, given that you've had a few patients that have gone to the 2 to 3 month mark that haven't been fully cured, do you suggest maybe considering carrying it out even longer than 2 to 3 months potentially, or not at the moment?
Um, well, I mean, I've had patients who've been on it longer, but not at the so-called target dose, which is like, it's, I'm calling it a target dose. What I think is an optimal dose for their weight. I've not extended it beyond 3 months at that dose, but I have had patients on it longer who are in that ramp up phase or who, for various reasons, are their condition has been precarious and they're doing extremely well on these very small doses. So I do have a few patients who've been on it beyond 6 months, but not at the target dose.
Okay, so at least for now, you don't see the need to take the full target dose any longer than 3 months.
I don't have the experience to know that it's
Right.
a, a suggested strategy. And again, I'm trying to, hoping that you can use it for a finite period of time and not require people to be on this, for years at a time. And although for the use in alcoholism, sometimes it has been used for a year or more.
Is there anything that you think that might help potentiate the treatment? I know some people believe that heating up the body. I know there's a hyperthermia treatment option, like maybe saunas, maybe a biofilm buster like serapeptase, maybe something like grapefruit seed extract that's been shown to help break up that stuff. Is there anything that you think might help be a potentiator or adjuvant to the effect of disulfiram?
I don't know the answer to that. From my point of view, I'm trying to keep it simple and see if simple works. And then I guess there might be a role to see what other interventions might, improve the effectiveness. Because not everybody is enduring remission, So, but those are questions I can't answer.
I'm assuming, given that you said so earlier, that in some cases you do think it's okay to use antibiotics simultaneously with disulfiram, right?
Yes, I mean, those first three patients, in order to not have the situation confused, I insisted that they go off their antibiotics. And generally, I'm having patients do disulfiram as a monotherapy, with some exceptions. And again, because I don't have any convincing data to let me know that it's effective against Bartonella, and as you know, for some of the patients, Bartonellosis is a big issue, and that the one patient where she was treated with treatment for Bartonella along with the Disulfiram, at least from her perspective, she did not perceive that the Disulfiram eliminated her need for further treatment for Bartonella. So again, it's not a lot of data that I'm working with, and I think I've told you some of my colleagues who are also using Disulfiram are of the opinion it might have effectiveness against Bartonella. But I think that, again, we need a lot more study of that. But
One group member brought up the fact that some Lyme doctors are insisting that patients stop antibiotics for 3 weeks prior to starting Disulfiram. Do you recommend that, or do you know why they might be recommending that?
well, you definitely want them to be off of any of the agents like tinidazole or metronidazole, because you can definitely have adverse drug interaction between Disulfiram and those agents. Um, that's the one agent where I would insist that the person would stop that for at least a week before starting Disulfiram. I'm not sure about the other agents, because we've had patients where they began the Disulfiram fairly shortly after discontinuing their antibiotics without a long delay.
Have you thought about how doxycycline might drive the bacteria into the persister state, and whether or not that might be beneficial or contraindicated for the therapy, or other antibiotics? It doesn't have to be doxycycline.
I don't know. I mean, it seems from the work that Dr. Shafi and others have done that traditional antibiotics commonly have that effect of driving it either into cystic phase or into round body or even biofilm. And that's the other speculation I have about Disulfiram, is that one of its metabolites is carbon disulfide, and that is known to have antibacterial properties. And it's also a very small molecule, on the order of the size of carbon dioxide. So in biofilm has metabolism. So if biofilm is a bona fide issue in Lyme, which I have reason to think it is, it's possible that that Disulfiram may have good activity also at Borrelia, other organisms within biofilm. So that might be another reason why it may be more effective than many of the antimicrobials, which are often quite large molecules.
So you think that it may actually be penetrating the biofilm because of that small molecular size, right?
Yes. Look at the periodic table. Remember that? You ever take chemistry?
Yeah, I have, definitely.
Well, sulfur is directly below oxygen on the periodic table. So it's a small atom, and carbon disulfide and carbon dioxide are, they're both small molecules, and therefore very diffusible.
Have you had any patients that combined disulfiram with ozone therapy by any chance?
No,
And you're not aware of whether or not that's contraindicated?
I don't know.
Okay.
No, I know there are a lot of patients who feel they benefited from ozone therapy as a biooxidative approach.
I had a couple questions about Babesia. Obviously, you've had good results so far with Babesia. One person has said some patients who were asymptomatic before taking disulfiram are noticing their Babesia symptoms appear to be reactivating from disulfiram. Is that to be expected, given that it may be hitting Babesia?
I'm not sure. That case 3, who was really, had very significant babesiosis symptoms, and at any time he would stop his high dose Mepron and Zithro, within a few days he'd have drenching night sweats. He reported that even at the lowest doses of disulfiram, that his babesia symptoms seemed to melt away within a fairly short period of time, which is very impressive to me.
So that leads me to the third question. You don't currently see the need to recommend other Babesia treatments concurrently with disulfiram?
Well, perhaps I'm naive, but I'm hoping that the disulfiram might be, make those unnecessary. And besides, they're not wonderfully effective as it is. There's a new anti-malarial agent that has come out. Get the name of it, but one of my colleagues pointed out that it has some quite serious potential toxicities, a very high rate of corneal corneal injury, I think. So whether that's going to have a role in babesiosis, I don't know. I mean, it's for malaria right now, and it's new.
Oh, interesting. A couple of questions about Bartonella. We answered most of these questions already. Obviously, you think it has no known effect to Bartonella right now. But I guess the question here is, some patients are reporting an increase in their Bartonella symptoms while on disulfiram. Is this happening in your patients, and does it seem to be a Herx or BART reactivating?
Yeah, that's a good question because as far as whether to be treated for Bartonella concurrently with the use of disulfiram or not, um, again, from a certain point of view, it makes it easier to just do one thing at a time and see what happens. And some of my patients, even those who have Bartonella, have opted not to treat their Bartonella while they've been on disulfiram. And I told you about the one who didn't want to not be treated, and I let her stay on. And I'm also trying to think. I have two patients right now who had evidence of Bartonella, and the decision was made not to treat the Bartonella while they were being treated with disulfiram, and they are having certain symptoms that we're scratching our heads and wondering whether those symptoms are not from Lyme, not from babesiosis, but from Bartonella that's not been treated, you know? And I think those two patients are coming in soon to be reassessed, including some direct detection testing methods to see whether or not we can actually prove that Bartonella is the reason why they're having certain symptoms. They were stopped because they were having neuropathic symptoms, but they'd been on a fairly long course, so we thought it was not inappropriate to discontinue the disulfiram anyway. Um, yeah, so that's a good question. Is it a mistake not to treat Bartonella while with other means while you treat Lyme and babesiosis with disulfiram? That's a good question. I don't know.
So uh, do you currently treat Bartonella with disulfiram? Sorry, do you treat Bartonella infections alongside Lyme infections, or you typically do them separately? If you haven't answered that already.
Um, well, I usually have a discussion with the patient and give them the option of deferring Bartonella treatment while we do the disulfiram, since usually the disulfiram is for a somewhat finite period of time, and then with the understanding we can always go after Bartonella later if it seems appropriate and necessary. And but some patients have declined to not treat the Bartonella while we're using disulfiram, and some patients have opted to defer treatment for Bartonella. And some patients that have gotten away with that and seem to do okay, but now I'm raising for consideration for you and for me that maybe some patients that's not a good strategy because it may enable you might be treating the Lyme and the Babesia, but it might be enabling the Bartonella to be essentially untreated during 4 or 5 or 6 months while you're treating with disulfiram, and maybe that's not a good idea.
I I believe you touched on this earlier, but what do you recommend for people with candida issues if they're going to get on disulfiram? Do you have any recommendation?
Well, yeah, I mean, again, I haven't been using disulfiram with the idea that it's an anti-candida treatment, although there's some literature to suggest that it might be. So I mean, I would probably use the standard things that I would use like nystatin, or if it's more systemic and difficult to treat, I think you can use fluconazole along with disulfiram. Those would probably be the the two things that I would typically do.
Interesting.
Hasn't come up that much.
The one thing that I was a little concerned about is I know that Candida does produce acetaldehyde in the body, and
Hmm.
that may cause, I guess, the disulfiram ethanol reaction, right? Theoretically, from the acetaldehyde.
Theoretically,
So
yeah.
patients should probably try to minimize their Candida load in the gut before starting treatment. I would assume would be a prudent idea.
Well, Candida can be pretty uncomfortable. So yeah, sure. I mean, I don't see why it would be a bad idea to try to get that under control before you did that self-ram. Then the question is, how much of an issue would the whatever acetaldehyde? Well, I mean, Candida ferments things, right? So I don't know how significant that extent of um, fermentation products of Candida would be when you actually apply disulfiram. I don't know the answer to
Okay. What are your thoughts on the mechanism of action of disulfiram in vivo in people versus in vitro? Do you think they are different, or do you think they're similar, or you're not sure?
I really don't know. In my article, I speculated on the different things that I thought might explain its antimicrobial action. But again, I think everybody realizes we actually don't really know exactly how it exerts its effect.
To your knowledge, though, do you think Borrelia could build up a resistance to disulfiram, or it's too early to tell?
I don't know, but it's not an antibiotic in the usual sense. So a lot of those concerns about development of resistance, I mean, they're good questions to raise, but we don't know if that's even an issue, being that it's not, again, not an antibiotic in the usual sense. And I mean, I just don't know the answer.
There has been some question as to whether or not a supplement called glutathione or N-acetylcysteine and vitamin C may impair the action of disulfiram. Do you know anything about whether that's contraindicated?
Do not know.
Okay. Um, and you're not sure whether or not the metabolites of disulfiram are actually killing the Lyme or the disulfiram itself. I mean, we know disulfiram itself kills Lyme, right? But I guess we're not sure if the metabolites are very important.
Yeah, I mean that's interesting because the work that Potaneni and Rajadas did was in vitro, right? So presumably, unless the drug just in vitro goes ahead and breaks down to you couldn't call them metabolites, but I guess just in vitro breakdown products. How stable is it, and what was it in the in vitro that was reducing limiting the really was it the parent drug per se? Was it some non-metabolically broken down products? That's a good question. You'd have to know in the test tube, does it remain disulfiram, the parent drug, or does it somehow break down to other things even in vitro? Again, I don't know the answer to that.
Do you know if disulfiram might cause a reactivation of latent viral infections? Because we did see one article that it may reactivate HIV. So some patients are concerned that it theoretically could reactivate EBV or other herpes viruses.
I don't know the answer to that. Again, there's a vast literature on disulfiram, and the drug is being what they call repurposed for a lot of other indications, including use in treating different kinds of cancer, which is quite interesting. And also, in view of the work of Alan MacDonald, in which he states that he thinks there may be a link between Borrelia infection and glioblastoma multiforme. It's interesting that disulfiram apparently has activity against glioblastoma multiforme.
Oh, wow. That's promising. Yeah, I heard it's also anti-cancer for other cancers as well, right?
Apparently,
Do you know if the polyols like xylitol and erythritol, which are sugar alcohols for those who don't know, whether those are a potential problem on disulfiram?
I'm not sure.
What about the
Good question.
other forms of alcohol that are out there? There's a lot of skin creams that have various different forms of alcohol. Is there any consensus on which ones are definitely no-nos?
I don't know.
Okay.
I
So I guess it's pretty safe to say if you want to be on the safe side, just avoid anything that has any kind of alcohol in it. Because to your knowledge, there's no safe type or version of alcohol on disulfiram, right?
I might not be knowledgeable enough about how disulfiram would work with some of these other, things that have, you know, various types of alcohol. We're talking about usually ethanol, ethyl alcohol. But I guess I still just don't know the answer. And is it necessary to eliminate every cream, every toothpaste that has alcohol in it? I don't know. And obviously, there's some of the patients on your chat who've gone to great lengths to research, completely alcohol-free, alternatives to the usual, you know, um, things for toothpaste and different kinds of skin creams and whatnot.
But so your patients haven't really felt the need to do any of that, I assume.
No, I told you one patient who felt that he experienced I said a disulfiram reaction to just having a skin swab for a blood draw with isopropyl alcohol. That person might be just a very very sensitive person who can perceive these things. So no, most of the patients have not, with the exception of eliminating the usual alcohol things, and with the few oddball things that I mentioned, like somebody having a reaction after eating a slice of pecan pie, and somebody else having a problem with eating shepherd's pie. But yeah, but alcohol is hidden in a lot of things, so she can't be too careful.
Yeah, and this has been something that a lot of people in the group have been arguing about. Some people are saying you should avoid any foods with high amounts of acetaldehyde. Some people are saying no, it's not an issue. I've spoken to Dr. Rajadas at Stanford about this, and his perspective is foods with disulfiram seem to be fine for most people, except he would avoid vinegar, which has the high acetaldehyde. But things like coffee and melon apparently have fairly high levels of acetaldehyde, but he doesn't believe those are a problem. Is that consistent with your experience with patients?
Um, yeah, I mean, patients generally haven't had too much problems other than avoiding alcohol and the few exceptions that I mentioned. But um, we're always interested to hear patients' experience, and sometimes we learn things that we wouldn't have suspected, otherwise.
So, is it safe to say that you do have patients that are drinking coffee without any problems on disulfiram?
I believe so. I haven't made a big issue about avoiding coffee, and I haven't so far. I haven't heard any reports that I know about where that's caused a problem.
Okay, that's good to know. There's a few other of the co-infections that people were wondering if you had any insight you wanted to add, such as Ehrlichia, Mycoplasma, Yersinia, anything that is Rickettsia, or any of the other co-infections with Lyme that you want to comment on.
Don't know.
Okay, so nothing of note there. Um, so I guess in conclusion, can you summarize for us disulfiram and its potential for treating Lyme disease and co-infections, and are your views evolving as you see more patients treated with it, noticing any notable patterns?
Well, like I said, I think I said at the beginning, it's an agent. It's an option that we did not have before. It seems to have a lot of advantages over customary antimicrobial therapy. Its role is still being evaluated. My experience with it is still quite limited. No more than 50 patients over the last like 2.5+ years. Uh, I remain very impressed by its utility, um, and quite dramatic. I don't think it's necessarily going to be the solution for every patient, and there are going to be patients that they either can't take it or they use it and it doesn't seem to resolve their problem. So the question is, are they dealing with Lyme? Is there some other issue, or are there some patients where it just doesn't work for them? It is relatively safe. It's quite inexpensive when you compare it to a lot of the other agents. It does not require a parenteral approach, and it seems to be at least as potent or possibly more potent than some of the agents that have been thought to be the best agents that we have, like Rocephin or ceftriaxone, which are expensive, have complications of their own, and you often need you need parenteral approaches. So it can eliminate the need for IV antibiotics, I think, in many cases, and it's practical. But everybody needs to learn about it. The practitioners need to inform themselves about it, and the patients need to inform themselves about it. And I think, like any therapeutic, it needs to be used with care. And anything that you resort to therapeutically has potential adverse effects, and you need to people need to inform themselves about that. And I think for myself personally, I'm refining my approaches and trying to figure out what's the best way to use this agent. And definitely it's a learning curve. I think it's great that there are some formal trials with this agent that are, going to be going forward. Dr. Fallon has his study, and I just heard that apparently there's another study of disulfiram in patients, I gather that's going to be held out at Stanford somewhere. So, and then more and more practitioners, based on my reported experience and also personal communications with them, are beginning to use it. And I think feedback I've gotten from them is they're also quite impressed by its potency. And then, as I told you, I was interested in, I'm only dealing with 40 or 50 patients, and I learned about your chat group and other chat groups on Facebook, and I decided to join them to learn myself from the other patients' experiences beyond my own practice. And we're all learning together, and I don't think this is definitely not all wrapped up. So,
The Columbia study at with Dr. Fallon, that one hasn't started yet, has it? I don't believe.
I think they're accruing patients. I don't know if they've actually begun the study yet.
I'm from my understanding, Dr. Richard Horowitz actually has over 100 patients that are under some sort of trial under his watch. Do you know anything about how that might be going? Have you ever spoken to him about disulfiram?
No, I haven't, but I see that he has a 3-armed study with a couple of different groups. Disulfiram alone, disulfiram with some of his other regimens. So he's been pretty prolific in reporting on his patients, which is great. And it'll be interesting to see what his experiences are.
Most of the patients that you've done, just to get finality on this, most of the patients that you've treated with disulfiram were not simultaneously treated with other antibiotics, though, right?
That's correct.
Okay. Well, I really hope we'll be able to follow up with you in a few months, and hopefully we'll have a lot more knowledge and perspective at that time. And I really wanted to thank you very much for all the time that you spent here. It's been 2.5 hours, and I know the community is going to tremendously appreciate your insight, and just can't thank you enough.
Well, you're welcome, Harrison. I think it was very enterprising of you to set up your disulfiram group, and also the other patients and patient advocates who set up their own groups. And I made a joke about this, but I'm a trumpet player or a cornet player, and one of my teachers, William Spalding, who is a proponent of bebop, he used to tell me about the days when he used to participate in what is called the University of the Streets, where jazz musicians would get together and they would play on the street, and they would learned from one another, and that's how people got better. So I kind of jokingly call the Facebook groups a kind of a university of the streets, where patients are sharing their experiences, and we're all learning from one another. So it seems that there actually is a real group called University of the Streets. You can Google it. I think they have their own Facebook there. I think they're headed out of the Bronx, and they have a lot of different things. But one of the things they do is music education and jazz. So yeah, this is our kind of Disulfiram University of the Streets, right?
Wow, what a great analogy. Yeah, I feel this. I feel the same way. It's everyone's learning as we go. It doesn't seem like that happens very often with a lot of other drugs, but I guess Lyme is such a challenging disease, and as are the co-infections, that it makes sense that this is probably, and it's just great that the internet has enabled the ability for this information to pass freely all over the world, and it's hopefully will lead to an accelerated cure. I'm sure it already has.
Yeah, one of the thing, Jenna Luche Thayer, you know who she
Yep,
is.
I've seen her in the group.
Yeah, well, I don't know if she's in the group or not, but she's the one who promoted this ad hoc committee to get the ICD codes changed.
Hmm.
So she was instrumental in that, and she's got a big background in human rights. She and one of her friends is a pharmacist, and they are, I think, sometime this month. I think they've been doing a lot of work putting together a lot of the research and the pharmacology on disulfiram. And I think when that comes out, I think people will find that very, very valuable, I expect. So that's something to look forward to. Hopefully, I think they said they hope to have it ready to get out there by the end of September.
Wow, brilliant.
That would be great. So before we wrap up, is there anything that you want to add?
I would say just for everybody using this agent, be careful, be cautious, desirably be be working with a healthcare practitioner, and also just to be careful not to be overzealous in the use of this agent, and respect it, and be aware. Again, try to maximize benefit, and I guess one question is know when to stop.
Hmm. Can I ask one thing on the liver enzymes? You said that if the liver enzymes get high and there's this Murphy's reaction. Obviously, with the Murphy's reaction, that'd be quite obvious that there's some sort of liver problems going on. But what would you class as unacceptable liver enzymes? How high would they have to be before you say that's it, no more DSF? Twofold increase, or?
And by the way, do you want to identify yourself for the?
Oh, sorry, it's Fiona.
Fiona. Well, we've been impressed by how remarkably boring the surveillance labs have been overall. If I see liver function tests, I don't really have a clear cutoff, but certainly if they're progressively rising, that's a warning sign, because you don't know where they're going to end up,
Yeah.
So I usually don't get too upset if liver functions are, 1 to 2 times the upper limit of normal, but if I see them progressively rising while the patient is on disulfiram and there's no other reason for it, again, prudence dictates.
Can I just ask something? Somebody said that it was 2 different liver enzymes that tended to go up with DSF. They said, I think, is it ALT is the normal one that goes up? That's quite common. But they said it was in combination with another liver enzyme pointed to it being DSF. I don't know. I don't know about it. I'm just asking.
Well, the 2 patients where we did discontinue it, and one of them had a positive Murphy sign. I think it was the ALT that was elevated. But I usually check AST, ALT, and actually the GGT is one of the more specific enzymes for liver.
GGT.
Yeah, gamma glutamyl transpeptidase, and also a bilirubin as well.
Yeah. So if it's 1 or 2 times higher than the baseline, you would say that's not a cause for concern unless it's continually increasing.
Yeah, I mean, progressive increase is definitely a cause for alarm.
Okay, thank you very much. That's great. That answers that.
Okay, well, I think that's pretty much it. I just wanted to say, on behalf of everyone in the group and everyone who's suffering with Lyme disease, that I truly thank you, Dr. Liegner, for all your help and also work in this field. And I also wanted,
What?
go ahead.
Sorry. Well, one last thing is, it's amazing what you can accomplish when you get over the denial, and acknowledge the problem. And I truly believe that, disulfiram is useful, but I don't think it's the only agent. And I am very hopeful with the great work done by Dr. Rajadas and his group, Dr. Lewis and his group, Dr. Shapi and her group, and Dr. Zhang and his group, that we will have even more options that patients can avail themselves of. And that's what we need. It's good to have options. And this, disulfiram just kind of fell into my lap. I wasn't going out looking for it. And we had these rather amazing results for those first 3 patients. So, it's a tremendous amount of work to get anything published these days. And I felt, it was worth going to the effort to get it published. And I'm glad that I did.
Thank you very much.
Yeah, you were definitely the trailblazer.
Thank you.
You were definitely the trailblazer for the Lyme LLMDs. I did.
Well, it was the patient who was the trailblazer. Actually, I invited him. That case 1, I invited him to like come to the conferences and speak. And he's a very self-effacing guy and was not looking for any glory. But I mean, it's really, in this case, it was the patient who was really the pioneer. But I listened to him. I didn't think it was unreasonable, so I cooperated with him, and then kind of hit a home run out of the park unexpectedly.
Yeah, so I guess we should also give credit to all the charities that helped fund the research. It seems like Bay Area Lyme, Global Lyme Alliance, and then the Live Lyme, I think it is. Charities that have donated a lot of money, and then Stephen and Alexandra Cohen Foundation, I think, donated a lot of the money that those foundations use to fund this research. So I just want to make sure that they get recognition, and then obviously Dr. Rajadas for the initial discovery of disulfiram's efficacy. And then I guess, go ahead.
I think that initial research, if I'm not mistaken, a lot of that was funded by the Bay Area Lyme people, those original articles. But I would like to make a pitch for Dr. Rajadas and his group. I mean, they are doing they did the foundational work on this, and they are continuing to do excellent work, and they do need support. And I would encourage anybody who can to try to support them. And I know that I personally made a donation to their research early on, and usually it requires, it has to be a check to Stanford University, but I specified in my check that it is to be allocated to the Lyme lab of Dr. Rajadas.
Yeah, I'm hoping to interview Dr. Rajadas about this as well, and if there's any way that people can donate, hopefully we can give the exact details on that in that interview in the coming weeks. But I just wanted to also thank everyone in the group who submitted questions. I think we got over 200 questions. And hopefully we got your question answered. Sorry if we didn't. There was a lot of different questions that came in, and
yeah, there were some questions I couldn't answer. Like I can't give specific advice to a specific patient. There's a lot of reasons I can't do that, obviously. And there were some questions I just didn't know how to answer. Thank you.
Yeah, and I also wanted to thank Joseph Kulandai, Fiona, the moderator, and Sebastian, the moderator, as well as Rebecca, who all helped, editing the questions and making sure that we put in at least the bulk of them. Well, thank you, Dr. Liegner,
Okay.
and thank you, Fiona, as well as Sebastian, and hopefully everyone will appreciate this video. And maybe in a few months we could do a follow-up video, maybe 6 to 9 months out, if you have the time and have more information to share. That would be much appreciated, I'm sure.
Everybody enjoy the day. It's a beautiful Sunday here in Dutchess County.
Yeah, it looks nice out there. All right, Dr. Liegner, thank you again, and we'll be in touch. Cheers.
And good luck with the ILADS conference as well, with your presentation.
Thank you.
Thank you.
Bye.